Thank you so much. I feel so close to my friends and colleagues in India. I've of course been there many times and have had many visitors, and it's a very special relationship that I believe I have with the Indian vitreoretinal community as well as the nation. And my heart goes out to your country for the pandemic crisis that I know is so hard on so many people, especially people that are poverty stricken, and we feel bad for that. Let me share my screen and we'll get on with my talk here. Complex retinal detachments, there's no hard definition of what's a complex retinal detachment. So I've listed the three things that are more difficult for all of us: giant retinal breaks, PVR, and diabetic traction retinal detachments. And I'm going to take them in that order. And the notion behind the talk is, instead of giving history and statistics and showing pictures and videos, I'm going to list what I think are crucial mistakes people make that I see over and over and over again when people show videos and they call me on the phone and email me about their cases, or I'm visiting professor. So I'm going to list the mistakes that I see made over and over again, at least in my opinion, they're mistakes. And I'm going to list what I consider the essentials to doing a good job in these challenging cases. So with respect to giant breaks, the biologic problem is PVR, but the surgical problem is retinal slippage during the exchange process. We all know that Stanley Chang brought us liquid perfluorocarbon, which is absolutely magical to put the retina back where it belongs, and we're so indebted to Stanley Chang's work. So when you then exchange it for gas or silicone oil, often the retina will slip. This is technique driven, as David Wong has emphasized. If you're meticulous about the technique, you can get around it, but it means that you have to put the cannula at the interface in the far periphery, and that does lead to lens bumps. And if you do phaco and break the capsule, you've created another set of problems. So what I've used for all inferior detachments, as well as all inferior, temporal, and nasal giant breaks, is what I call medium-term PFO. We all recognize that perfluorocarbon was approved as an intrasurgical tool, not as a short or medium-term tamponade. I do not use the so-called heavy silicone oils. They create an inflammatory process. But what I've done for over 21 years in over 1,000 cases of retinal detachment is to leave the PFO in. Now, clearly that won't work for a superior retinal detachment, but for a temporal or nasal giant break, the patient can lie on their side. It works absolutely great. And there's no slippage because you're not exchanging it. For inferior, it's perfect because the patient can stand up, walk around, go to work, fly in an airplane, unlike a gas bubble. So I use this medium-term PFO technique for all my inferior detachments, but it's particularly advantageous for inferior temporal and nasal giant breaks. What are the essentials? I do not believe in using multiple spots of laser in any case. This is an anachronism that comes about from cryo or even diathermy, where you can't move the probe. There's no reason for spots that are separated or multiple rows. You have a far more uniform adhesion between retina and RPE if you use confluent lasers. And the confluent laser sort of smears the thermal profile, so it evens it out, whereas a normal laser spot's hot in the middle and cold on the edges. Always excise the anterior flap. And this is analogous to what I'm going to talk about in retinectomy and PVR. Scleral buckles are bad news for these patients. They actually encourage slippage. There was sort of an insider joke years ago. Machamer would do a buckle on the PVR cases, write a letter, say the retina is substantially reattached. Yeah, that meant attached on the buckle, but not behind the buckle. People don't see with their equatorial retina. I'm sorry. There's an obsession with combined phaco. If you've got a 20-year-old, they're not going to get a cataract from vitrectomy. Nuclear sclerosis progression is the rule. Clear lenses remaining clear is the rule. So only use phaco if you can't see what you're doing. Do not use a short needle, a 1/2-inch needle, to inject the PFO. It causes multiple bubbles and they end up getting in the subfoveal space, which is bad news. If you use the Med1 cannula, which I did not invent and I do not have a royalty on, I have no financial interest in Med1. The Med1 dual bore allows you to have a normal interocular pressure because there's a fluid egress path. And now you can inject with this flexible polyimide cannula at the right level. And we'll talk about that, but in a moment. And excessive retinopexy, instead of saying this is a bad case, we got to do more retinopexy to hold the retina down. Don't do it. Cryo is terrible. It causes PVR and it causes slippage of the break. So when the dual bore cannula has an egress channel, and so you should start with the tip of the dual bore cannula at the optic nerve head, make a small bubble, and then keep the tip of that yellow cannula that you see there, the pale yellow transparent cannula, in contact with the top surface of the bubble, and slowly withdraw as you inject. If you do that, you won't waste this precious, expensive PFO, and you will have a full fill without multiple bubbles. I use only the Alcon for fluoron. As some of you may know, there was a batch of PFO from India that was toxic. I don't use perfluorodecalan. I don't have any evidence that the perfluorodecalan's bad, but the index refraction isn't as different as it's just not as easy to see because the index refraction. So obviously the subretinal fluid, as well as all infusion fluid and liquid vitreous, all floats to the top, and you want to get rid of absolutely every drop of that. So people say, oh, you mean I can do a full fill? You must do a full fill. Oh, I'm afraid to do a full fill. Why? What do you think is going to be the problem? If you fill it all the way to the back of the lens or the IOL, or in the pseudophakic eye, fill it almost into the anterior chamber, then you have less aqueous material, whether it's aqueous humor or liquid vitreous or infusion fluid left over at the end of the case, to cause slippage. So full fill, mandatory. And this emphasizes that point with the word complete on the left. And you can see how, as I finally filled it near the top, there's a very flat angle to this cannula, so the egress channel, and actually rotate the eye over a little bit so I get the last little bit of fluid out. And this shows the confluent laser that I emphasized, and the excision of the anterior flap was not well depicted there. What about superior giant tears? Well, you have two choices. You can exchange for oil, which you must do if there's PVR, or if there's no PVR, you do have the option of exchanging for gas. And but how do you do that? You don't have three hands. So you either use chandelier illumination, which has the problem of glare, but you can use the malleable Alcon one and aim it in the right place. I always use the Alcon VFC on the console at 80 PSI to inject. The other option that I only began to do recently is slower, but it allows you to do 3-port without a chandelier. And that is Med1 makes a PVC tubing instead of silicone rubber that snaps over a non-valved infusion Alcon infusion cannula. So that works real well, so that you can have the extrusion cannula in the other hand and the endoilluminator in one hand, and have sort of standard technique. So I tend now to use that method. I don't use it in PVR cases because it's much slower in terms of the oil injection rate than the method in the first bullet point. Again, it's extremely important during the exchange to do sort of the inverse of what I described with the injection process. And that is, and this, again, something that we must credit David Wong from Liverpool, and that's to keep the tip of the extrusion cannula right at the oil or gas interface with the PFO in the periphery. So there's a meniscus of BSS, subretinal fluid, and liquid vitreous there, a little thin meniscus. You want to get rid of every bit of that. What I've seen people do is put the soft tip cannula at the optic nerve during the exchange, and sure enough, the retina slips back, and now they're trying to manipulate it mechanically and bumping the pigment epithelium and causing PVR or having to start over. So it's very, very important to do this exchange properly. This is where mistakes are made. To do that, you must focus down. I use only Ingenuity for visualization, but whether it's Ingenuity or the microscope, you must use the highest magnification and follow focus. I used to work in TV. I put my way through engineering school being a TV engineer, and we call it follow focus. So you follow that interface between the PFO and whatever you're exchanging for, gas or oil. So you keep that that extrusion cannula tip at the interface as it moves down, again, in the periphery, because the fluid meniscus is thicker in the periphery than it is centrally. So you don't want to be at the apex like you are when you inject. So this shows you that technique of exchanging and removing all of this BSS. Now let's switch gears and talk about PBR, so I don't run out of time. I invented retinectomy exactly the same time Macomber invented relaxing retinotomy. And we presented at the same meeting in Los Angeles. Often Macomber is credited with inventing this because of his prominence in the field, but in fact he didn't. But what matters is not who invented it, but how to do it properly. What's the difference? There is a substantial difference. Macomber made a circumferential cut and left all the tissue anterior to it. If you look at the silicone oil series, there was a 22% incidence of hypotony. That is absolutely caused by bad technique, namely heavy cryo, buckles, and more importantly, leaving this anterior tissue. So when you make a circumferential cut in the retina, excise everything anterior to it, just like in a giant break, you excise the anterior flap. If you leave that tissue, for one, if it's anterior to a cut, you can't see with it. The notion, well, it might cover the pigment epithelium. It doesn't. It scrolls up and it covers the ciliary body and causes a point Macomber made. Macomber from German used the language Ringschwelle, and that's residual capsule, cortex, peripheral vitreous, anterior retina, all in one ring that runs around the eye. That's what leaves the epiciliary tissue. I polled my ex-fellows via email and asked them, how often have you seen hypotony from my PBR cases? Not one person could remember a single case. And I go to meeting after meeting where they talk about endoscopic surgery to remove the tissue on the ciliary body. Doing Macomber's relaxing retinotomy technique is a major cause of that. It also causes more PBR, as John Lean and I have reported. Don't do a scleral buckle. Scleral buckles, patients pay money for, or doesn't, even if they don't pay money for it, doesn't matter. They want a good refractive outcome. You induce around 3 diopters of axial myopia when you encircle. There's no randomized trial evidence that a buckle improves the outcomes in PBR. Day in, day out, I reoperate other surgeons' PBR cases that they send me or somebody else sent me, and there's a giant buckle in the eye and all the retina is detached posterior to it with PBR all over it, and the breaks are posterior to the posterior edge of the buckle. It makes glaucoma filtering procedures a nightmare. It causes ocular surface disorders. It causes strabismus. I've done 8,000 vit buckles, but I got over it and I learned not to do it anymore. And I haven't been doing buckles, period, for around 15 years and maybe more. And that's important. So if you do a lensectomy, don't leave the capsule because you're going to put a sulcus lens in later. The capsule sticks to the back of the iris. They get a concave iris. They have more epiciliary tissue and more hypotony. Excessive retinopexy causes PBR. Don't say, oh, this is a very challenging case. I got to do 6 rows of laser. Don't do it. If PBR comes back, don't take the oil out to reoperate. I've reoperated all my PBR and epimacular membrane cases under oil for over 30 years. It works absolutely great. It takes a short amount of time. It's less traumatic on the eye. There's many, many advantages to reoperations under oil. I've seen patients that have PBR with oil in the eye, recurrent PBR. The doctor takes the oil out, puts PFO in, which promptly goes underneath the retina, and then at the end they put the oil back in. What are they thinking? What's that PFO step supposed to be for? There's absolutely unnecessary to do that. Sorry, let's go back one. So what's the sequence of events? You always initiate in any detachment case internal drainage subretinal fluid, which I invented, before you do fluid air exchange. Always drain first. Then as the retina goes back under air, it may hang up and you say, oh gosh, I missed some vitreous. Don't start over and put fluid in the eye. Do vitrectomy, interface vitrectomy under air. Then you go farther back. You say, oh, there's a star fold I missed. Let's peel membrane under air. Then the retina goes farther back. Oh, the retina's, now that I see it, the subretinal fluid was turbid. I couldn't see it before. Now some of it's removed. I can see there's a subretinal band. Let's remove it or resect it. Then as you finally get back farther, that's when retinectomy is performed under air. Don't do retinectomies under saline. That's important. So I call this generically interface vitrectomy, under air, under PFO, or under oil. Now we know obviously that air and oil float, so the word under is in quotes. But what are the scenarios? One, the one I just described, where you notice traction during fluid air exchange. Two is if you noticed it after you put PFO in. I often do some more vitrectomy in the periphery with PFO in the eye, being careful not to be in the PFO space and remove it. If the retina is highly mobile, jumping around, making you nervous during vitrectomy, and this is much less common with the 10 and 20,000 cut per minute cutters. But anyhow, if that point you can put air in, and it'll work. If you have bleeding and traction detachment surgery that just you can't seem to stop it by raising the pressure, put air in. The bleeding will be confined to the retinal surface, and you can at least finish the vitrectomy under air. All retinectomy should be performed under air, not PFO. And then, as I said, all silicone reops should be done under oil without taking it out. How do you do that? If it's a epimacular membrane, you don't even have to add oil. If there's a subretinal fluid, then obviously you've got to inject oil as described here. And this shows you membrane peeling under oil. And this shows you an epimacular membrane under oil, and you just top up the fluid if there's a little shortfall. What about diabetic traction attachments? We only got a few minutes left, so I'll talk quickly. The notion that there's a linear algorithm, first do a core vitrectomy, then make a PVD, then do membrane peeling. That algorithm, one, is way too rigid and has nothing to do with diabetic traction attachments. Don't do forceful PVD creation. It causes atherogenic retinal breaks. And membrane peeling is totally unnecessary. So what do you do? Well, scissors delamination and cutter delamination are what you should do. The second common mistake I hear over and over again, people say, oh, with today's multipurpose cutters, there's no need for scissors anymore. And I say, well, how often do you put in oil? Well, these, are complex traction attachments. I usually use oil. What are they telling you? They're telling you they made iatrogenic retinal breaks. If there's no retinal breaks, there's no need for oil. If you're using oil commonly in diabetic traction attachments, frankly, you're not doing a good job. So you must use curved scissors in addition to the new beveled cutters. The cutters are way better than they were even 5 years ago. I love the Alcon 20,000 cut per minute bevel cutter. I can do more and more epiretinal membrane, but not all. You must have in your armamentarium the ability to use curved scissors for delamination. It's an essential. Don't use diathermy before cutting things. Wait until you delaminate with the cutter or the scissors. If it bleeds, elevate the pressure. If it doesn't stop, then use the laser for hemostasis. And there's absolutely no need for a buckle in these cases or for viscodissection or bimanual surgery. If you use disposable scissors, which means you then won't contaminate and cause toxic posterior segment syndrome from bioburden, then the scissors work well, and I find no need for bimanual surgery to stabilize. Bimanual surgery is not necessarily bad, it's just unnecessary. There's two types of delamination: fold back for flexible membranes and conformal. And this is what they look like. So if it's a rigid membrane that won't fold back, you've got to put the port right at the margin of the epiretinal membrane. You can't pull it up into the port. If it's flexible, you can put it on top of the membrane behind the edge of it, and it will fold back into the port. Both those work, but they're for different. This is rigid, flexible. So when do you need scissors? When the membrane's adherent to the macula, that's the tabletop traction attachment, typically, or if the retina is very thin and atrophic, which is more often nasally or in mid-periphery. So if it isn't necessary to remove every bit of epiretinal membrane outside the arcades, but if there's membrane that's causing the macula to be elevated or folded, then you got to do something about it. And if it's adherent to very thin atrophic retina from ischemia or from a chronic TRD or from prior PRP, then use the scissors, because if you use the cutter, you're going to make iatrogenic retinal breaks. Why is silicone oil bad? Because it does not, it has a very low oxygen extraction ratio. It confines cytokines like basic fibroblast growth factor and VEGF, and causes Mueller cell reactive gliosis at the retinal surface. When should you use vertical scissors? Never. Curved scissors are better for everything. The back wall of the eye is curved. Vertical scissors require more space to get in the potential space between membrane and retina. Always use curved scissors. What's segmentation for, which I invented? It's for access to the delamination plane by and large. Should you stick it in and open them? No. Should you stick the scissor tips in wide open and then close? No. Make small snips. Don't do this. Don't spread. You'll tear. Make small snips at the margin as depicted here. What's the direction of delamination? Inside out is better. Start at the nerve. Delaminate along the arcades. The retina is stronger. You can see what you're doing. The surgical planes are more visible there. Outside in causes more breaks. There's room for outside in on occasion, but instead of starting at the outside edge, outside the arcades, where you're more likely to make a retinal break, start at the nerve head and delaminate outwards in most instances. This shows you inside out delamination with a 25 gauge curved scissors, and this shows you removing the sheet. This makes the point that instead of you must make a PVD first, then deal with the retinal surface is wrong. If there's not a PVD, don't worry about it. Go centrally, delaminate inside out, and the outer margin of epiretinal membrane will be contiguous with the posterior vitreous cortex, and you can safely remove it then. Where does this fit? If there's no PVD, don't make one. Delaminate inside out first. It was called Onblock by Gary Abrams and a number of others in Milwaukee at the time, and Onblock is a stupid term and a stupid concept, because the original Onblock paper by them, I invented delamination, and I invented delamination before the PVD if you don't have one, but they went ahead and published it, put a different name on it, and block. But they were wrong on what they advocated. They said use the posterior vitreous cortex to pull on the membrane, which is a very bad idea. And the Onblock comes from cancer, where the point is to remove it in one piece. That's what Onblock is translated from. That means in a block, one piece. That's not what you want to do, because you're going to create remote traction. So it's very useful to do segmenting the delamination, segmenting into a couple pieces as you delaminate, so you're not pulling on the supratemporal arcades or the fovea when you're working on the infratemporal arcades, as an example. Peeling has no role. If it happens, just come off easily, fine. But don't start with picks and manipulators and spatulas thinking you can peel. Peeling's for macular surgery and PBR. And lastly, don't use diathermy for hemostasis. Use the laser. I published this years ago. The green 532 nanometer laser energy is absorbed in the hemoglobin blood column, which obviously green light's absorbed in red. This way, the energy is confined to the blood column, whereas there's collateral damage with the radiofrequency energy of diathermy. Well, that's all I wanted to cover. I guess I didn't run over with time, but about 2 minutes. I guess we're okay. So thank you so much.